So I guess the work that we presented was looking at inequalities in cancer, and specifically socio-economic inequalities. So we're aware that obviously we have inequalities in non-small cell lung cancer treatments, and if you have a low socioeconomic status, that means that you are more likely to have an increased mortality, decreased survival, and reduced access to conventional treatments, so surgery and chemotherapy, but not necessarily radiotherapy. And obviously we were exploring novel biomarkers and the therapies that go along with that, and their utilisation on this background of ingrained cancer inequalities within the system. And although, yes, you have a text to access a lot of these treatments, whether or not actually utilisation is still influenced by socioeconomic status because of these historic inequalities we have in the system. So we conducted a retrospective population-based cohort study to investigate this. So we used English National Cancer Registry data. And we have a new linked data set we can access through that called SACT to access the drug prescribing details. Obviously, we were looking at utilisation based on socioeconomic status, and in the cancer registry, that's measured using the index of multiple deprivation, so a scale from 1 to 5, so 1 being least deprived, 5 being most deprived. And we were obviously looking at the utilisation of these therapies, so targeted treatments, biologicals, and immunotherapies. And we ran logistic regression models and odds ratios, 95% confidence intervals to analyse this. And we found that if you resided in England in the most deprived locations, that you had a 46% less likely to utilise these treatments compared to those residing in the most affluent areas. And obviously when we explored different therapy subgroups, so I think one of our working hypotheses was whether or not some of these associations we were seeing was actually down to other sort of things going on, so whether or not a patient has a targetable tumour. So we explored sort of the comparison between immunotherapy, which isn't known to be biologically driven, compared with targeted treatments. And we found similar sort of inequalities. The patterning was the same. Yes, the association may have varied slightly, but you're still seeing these stark inequalities in utilisation, which is obviously quite concerning, and is something that needs to be addressed moving forward, especially because England is a publicly funded healthcare system, so cost isn't an implication for a patient to access treatment, and we're still seeing these inequalities in access to targeted treatments and immunotherapy within England, and that obviously needs addressing moving forward, because access to medicines should be equitable and not on the basis of where you live or your socioeconomic status.